Spinal surgery teaching. We invite Professor Ramani to talk on spinal surgery teaching. Professor?
Yes, spinal surgeon because I have completed 83 years, and as of today, I'm as active as I was 20 years back. Yeah. Safety in spinal surgery depends on two factors: healthy spine and spinal surgeon. What creates spinal problems? You all know the occurrence of spinal problems resulted in emergence of spinal surgery. Then there was technological progress, new concept came, there was progressive popularity, and today spinal surgery is at its peak. But how safe it is? That is the question. As you know, Lucy the ape hominin, the first chimpanzee to walk like human beings, 33.2 million years ago, was discovered on the 24th of November 1974 in Ethiopia. This is Lucy. From chimpanzee to ape to hominin, man learned to stand erect and look smart. He also started walking with elegance and grace. Animals are not known to suffer from spinal degeneration. The bipedal man prospered and used expensive clothing to look smart. The smart man developed bad habits of consuming coke, chips, and burger and forgot to do the exercise. He looked like a pig, and that was the emergence of spinal problems. Genetics are determined at birth. What are the delusions of behavior of spinal surgeons? Genetics are determined at birth. Epigenetics, which involves methylation of genes or histone capping, can be altered all the time. It is a reversible process. Each spinal surgeon is born under different epigenetics, which involves physical, physiological, psychological, and importantly, nutritional. The reason why spinal surgeons behave differently is because of their nature, discipline, maturity, and the viewpoint that is holding. A good spinal surgeon, a good spinal teacher teaches the residents to learn through heart, encourage them to participate in competitive program, give them the best training, even if it is meant sending them to other centers, and train them to achieve self-esteem, self-dignity, and self-reliance. Now, just look at this example. This female, 25 years, postgraduate resident in ophthalmology, had presented to someone with severe back pain and right sciatica. Right SLR was 15 degree, right ankle jerk was absent, and right S1 root positive perianal sensory loss was there. And these are the pictures. What would you have done? As far as I am concerned, I would have done a micro-lumbar discectomy. But the surgeon, this is what he did. He did 2-level interbody figure and 3-level pedicle screws with other screws going wrong. Is this justified? The pre-operative check, nothing is more distressing than to lose a patient from elective surgery. The doctor must try and assess medical morbidities properly and address them to keep surgery as safe as possible. Once you do that, then I can do even 2-level vertebroplasty and PLEF, and the lumbar canal stenosis PLEF, 2 levels I can do. In this patient was referred to me from somewhere else with spondylolisthesis. You can see that for PLEF surgery. When a clinically examined the patient, I found the jerks were very brisk and the patient had this knee clonus. So I was concerned. I said, what is going on here? So I started investigating further, and this is what he had. He had CBJ anomaly along with that. Once we knew that and we are correctly placed, then it was possible with proper intubation to do both surgery in the same sitting. Next. Pre-evaluation is absolutely important for spinal surgeon as well as the anesthetist, because many times you can get all the ankylospan, displaced airspace, prefix larynx, etc. All these issues can be very well solved if you know the patient in advance. You know? For example, we have got always laryngoscope ready, and once you know that, they can be very easily intubated. Yeah, next. Blindness in prone position. It is extremely disturbing, disappointing, and distressing for the surgeon to hear from the patient after surgery that he feels good in the back, but he cannot see anything. We follow this technique on the right side picture so that the eyes are very well protected. Just don't put just 2 pieces of the sticky on the eyes. They get a lot of pressure from there. And then, if you see in the middle picture there, we also use specially imported headrest. They're very gelatin headrest. So, in addition, we do this on the right side. Next. If we are doing intraspinal surgery, intradural, intramedullary, neuromonitoring is very, very important. Yesterday in the workshop, Dr. Parthivan also showed for laminectomy lateral mass, no harm, because in laminectomy lateral mass also, if the C5 nerve root it can get damaged, it is better to do it monitoring with the neuromonitoring. Next. You must be aware that within 2 months of uncoated stent angioplasty, blood thinners cannot be stopped for spinal surgery. Following coated stent, spinal surgery will be postponed for 1 year. Within 6 months of major myocardial infarct, spinal surgery is unsafe. Diabetes, obesity cause infection, delayed wound healing, phlebitis, and pulmonary embolism. Pulmonary disease and psychological problems have unfavorable outcomes. Implants in spinal surgery, most common topic in spinal surgery. Commonest implant used is spherical screw. You must understand the dynamics of the spine properly so that you can avoid all such issues coming to you. Next. Overuse of implants. Statistics prove that pedicle screw is overused. Implants have higher rate of complications. It also has higher rate of morbidity. Desire. What is the desire of a spinal surgeon? Generally, is a professional advancement, recognition for personal achievement. Very important. But financial gains in mind creates conflicts of interest, bias research, and influence decision making. Increased cost. Primary driver of increased cost is new technology. Increased cost versus clinical effectiveness needs to be analyzed properly by the spinal surgeon. Reality in the world, and that should each spinal surgeon should be aware what Mark Twain said: there are lies, damn lies, and statistics in the world. Quality of spinal surgeon. Yesterday in the inauguration, the governor in his speech told a lot of things that the spinal surgeon, how he should behave, etc. I would say that he should show integrity You should work with knowledge, dedication, and passion. Transparency, very important. Social benevolence. He should continuously establish rapport with patient. He should admit his fault and be honest to the patient. I tell you, in the long run, it helps to be lot to be very honest and be with the patient. So the prayer of a safe spinal surgeon is, the hill though high, I covet to ascend, the difficulties will not offend me, I perceive the way, for life lies there. And I have made this talk today based on my references which are published in World Neurosurgery. Thank you very much. Ganesh, are you there?
Yes, sir. Thank you very much for the ever inspiring talk, sir. And it was very nice to see you and listen to you again, sir.
Thank you. Thank you. Thank you.
Thank you.
Yeah.
Thank you very much, sir.